Welcome to Clinical Capsules from TRC Healthcare, your go-to podcast for fast, evidence-based insights. On this episode, assistant editor and clinical pharmacist Rachel Cole dives into the evolving landscape of acute migraine treatment, spotlighting 3 newly approved medications, Atzumi, Brekiya, and Symbravo, and how they compare to tried-and-true therapies, in an excerpt from our popular Pharmacy Essential Updates webinar series. TRC has been a trusted resource for healthcare professionals for over 40 years, and now we're bringing that expertise straight to your ears every second and fourth Tuesday in bite-sized, actionable episodes, right here on Clinical Capsules. And new, starting this month, this podcast offers continuing education credit for pharmacist subscribers at our platinum level or higher and pharmacy technician subscribers. Please log into your pharmacist letter or pharmacy technician's letter account and look for the title of this podcast in the list of available CE courses. None of the speakers have anything to disclose. With that, let's get started.
Our article says that 3 new meds for acute migraine have recently been approved. We're going to put the hype about these meds in perspective since they're just new versions of old meds and also outline their role in therapy. So, migraine is a complex neurological dysfunction leading to a headache with moderate to severe throbbing or pulsating pain. We usually see migraine more often in females, and genetics also plays a role since we see these types of headaches run in families. And there's still a lot we don't know about this condition. A migraine is usually felt on one side of the head, and patients often also experience additional symptoms with the headache, like nausea, vomiting, sensitivity to light and sound. And some patients also experience what's known as aura, which can look like flashing lights, blurred vision, or facial tingling. And migraine affects up to 15% of the general population. So let's meet Mary and keep her case in the back of our minds as we walk through the content today, and we'll swing back around to her as we conclude. So Mary is a 23-year-old female college student with a family history on her mom's side of migraine. Mary started to have migraines when college was especially stressful, and she's presently had 4 so far, about 1 migraine per month. She's only tried acetaminophen so far with little relief. She has no cardiovascular history or drug allergies, and we can think on some treatment options for Mary as we walk through the treatments. So there's 2 approaches when treating migraine headaches. Preventing migraines from occurring before they start, which is recommended for those having weekly migraines or 2 severe migraines per month. These meds are usually taken regularly to reduce the frequency and severity of migraine attacks, and they include CGRP targeting agents, ACE inhibitors, angiotensin receptor blockers, and several more that you can review on our updated resource, Migraine Prophylaxis, on our website. Abortive therapy is to treat migraines as needed, preferably as soon as possible when the migraine begins, and we'll typically see OTC non-opioid analgesics, triptans, and dihydroergotamines as an example. So in treating acute migraine, it's important to individualize therapy choices, and the choice should be based on what the onset of the migraine looks like. Is it rapid or slow? Are there other symptoms like aura preceding the pain? How frequent are they? How severe? Is the patient still able to work, or are they completely debilitated? Do they need to also manage nausea and vomiting? Do they have comorbid conditions like cardiovascular issues, since some of our treatment options have contraindications with these types of conditions? Recommend patients start their meds ASAP with the right drug and avoid medication overuse headaches, and consider combination therapy like possibly an NSAID plus a triptan. Medication overuse headache, also known as rebound headache, is a chronic headache condition that develops from the frequent and excessive use of acute headache medications. It's characterized by headaches occurring on 15 or more days per month for at least 3 months, following the overuse of pain relievers for other headache conditions. So in essence, the medications used to treat headaches end up causing more headaches. And some of the big culprits for this are the use of opioids or butalbital. These pose the highest risk for rebound headaches. Triptans are also a frequent cause, mostly due to their widespread use. Also, ergot derivatives or dihydroergotamines, also known as DHE. Then some combo analgesics, especially those with caffeine, and possibly lasmiditan, but has a much lower risk. Now let's move into our treatment options for acute migraine. These include NSAIDs like ibuprofen or naproxen, our triptans, acute CGRP or our gepants, lasmiditan or Rayvow, and our dihydroergotamines or DHE. So remember, we're always going to ask what the patient has tried before and the result, and that will give us a place to start. If adequate pain relief isn't achieved within 2 hours after a dose of a non opioid analgesic, like an NSAID or acetaminophen or a combo agent, recommend moving up to a migraine specific agent based on the patient's response in prior migraine, how well they tolerate certain meds, and their risk factors. So before moving up in treatment, the dose should be optimized, or you can possibly try a different NSAID. If the patient is not getting adequate relief from OTC analgesics, in general, recommend a quicker acting oral triptan, such as rizatriptan or sumatriptan, and think of naratriptan or frovatriptan for longer lasting or recurrent migraines, but these take longer to kick in. And think about it an injection or a nasal spray for patients who have severe nausea or vomiting. And don't rely on oral disintegrating tabs for quick onset since they still need to be absorbed in the gut. Recommend starting at the max single dose, such as oral rizatriptan 10 milligrams or sumatriptan 100 milligrams, and taking the triptan as soon as possible at migraine onset. And tell patients to take the same triptan for at least 2 migraines, with redosing if needed, before calling it a failure. And explain that it may take a few tries to find one that works best, and don't be surprised if you see some experts mix or alternate triptans, such as using an oral triptan for mild migraine or a nasal formulation if the patient is vomiting. But it is contraindicated to use two different triptans within 24 hours or to use a triptan within 24 hours of an ergot derivative. And if a patient uses any triptan more than 2 days per week, we want to consider a preventative approach to limit medication overuse headache. It's also important to remember that several cardiovascular conditions, such as heart disease, a history of stroke or TIA, uncontrolled hypertension, or peripheral vascular disease, are contraindications for using triptans. So this is one of our new meds. Symbravo is the new oral meloxicam 20 milligrams, rizatriptan 10 milligram combo tablet for acute migraine with or without aura, joining the only other NSAID triptan combo tablet, Trexamet or naproxen 500 milligrams, sumatriptan 85 milligrams. You'll hear reps tout that its delivery system enhances meloxicam's absorption and solubility to provide pain relief within 2 hours and up to 24 hours for some patients, even if taken later in the migraine attack. Symbravo has led to pain freedom in 2 hours in 2.5%, 8.3%, and 13% more patients than rizatriptan, meloxicam, or placebo, but there was no comparison to a triptan and NSAID taken simultaneously. And it cost about $1,100 for 9 tablets and may not be covered by insurance. So instead, recommend lower cost options such as taking these two meds individually or whatever NSAID and triptan combo works for your patient. So our CGRP antagonist may be harder to access than triptans due to cost or payer requirements, so consider these for adults who can't use triptans or who have failed 2 triptans. They're generally well tolerated. The current cardiovascular safety data is reassuring, and they don't appear to cause medication overuse headaches. This next medication works similarly to triptans, but on a different receptor subtype, so it has a different effect on blood vessels. Lasmiditan or Rayvow can be used in patients with contraindications to triptans or those who have failed 2 triptans. And this is a controlled substance, so keep this in mind. And the side effects include feeling tired and drowsy, so the patient should not drive or operate machinery within 8 hours after taking the medication. The other two new medications are different formulations of dihydroergotamine, Atzumi nasal powder, and Brekiya subcutaneous autoinjector. So these two medications will join the nasal spray and IV forms that have been available for years, but all are options for acute migraine with or without aura. But don't expect these new forms of DHE to change its role for acute migraine. We want to continue to save DHE for patients not responding to first line treatments such as triptans, and ask patients about any cardiovascular medical history, since DHE is contraindicated in uncontrolled hypertension, ischemic heart disease, and several other cardiovascular conditions, and carries risks for serious adverse effects such as stroke. And patients with factors predictive of coronary artery disease, like smoking or high cholesterol, should receive their first dose in a healthcare facility. Plus, it's contraindicated in pregnancy. And we can anticipate that these new DHE formulations will be expensive and require prior authorization. So, Atsumi nasal spray is indicated for acute migraine with or without aura, and the patient will pump the Atsumi device 3 times into the same nostril while inhaling to get the 5.2 milligram dose, and will not prime it before use or the dose will be wasted. The dose can be repeated once after at least 1 hour. Brekiya, or the new auto-injector formulation, is also indicated for cluster headaches in addition to migraine with or without aura, and patients will inject into the mid-thigh to deliver the 1 milligram dose and may repeat at 1 hour intervals with a maximum of 3 milligrams in 24 hours. For those patients suffering with nausea and vomiting, metoclopramide or prochlorperazine can be effective if needed, as these may improve the efficacy of the migraine medications by helping to manage the GI symptoms. Other options are ondansetron and promethazine. Some drugs we want to avoid as options when treating migraine are opioids and butalbital containing products. Since these have a high risk of causing medication overuse headaches, they have limited evidence of efficacy in migraine and can lead to rapid tolerance and have the potential of abuse and dependence. So, swinging back around to our patient Mary, what are the best options for initial treatment of Mary's migraines? Well, since she hasn't tried anything besides acetaminophen at this point with little effect, adding an NSAID would be a logical next step, like naproxen or ibuprofen, dosed optimally and with some food to protect the stomach. After trialing an NSAID acetaminophen combo, the NSAID can be switched, for example, switching to naproxen if ibuprofen isn't getting results, to see if she gets better results. Then we can move to trying a triptan, possibly sumatriptan, that has several formulation options. And again, the med should be chosen based on our individual headache profile. And then we can possibly move up to a triptan NSAID combo if needed. We'd want to counsel Mary about avoiding possible migraine triggers and see if she's already pinpointed anything. Some examples are waiting too long to eat. Hormones can be a trigger for those experiencing menstrual migraines. Emotional stress can be a trigger for Mary since her migraines started during stressful times in college, and we could help her strategize how to control her stress levels. And for those experiencing severe nausea and vomiting, migraines that intensify quickly or are occurring upon awakening, consider an injection or a nasal spray formulation to bypass the GI issues and hopefully have a quicker onset. So, to wrap up, we want to help patients identify and avoid migraine triggers. Recommend they take their migraine medication as soon as possible at onset, and also to be cognizant of medication overuse headaches and know when to suggest preventive migraine medications. Counsel patients on side effects of their chosen medication and consider the other medications they take and comorbidities, especially cardiovascular conditions. After choosing the best medication, it's important to monitor for side effects and adjust treatment as needed, and encourage patients to keep a headache diary to track triggers and treatment efficacy. And finally, remember our patients with frequent migraine and using acute migraine treatments are at risk of developing medication overuse headaches. So limit use of acute meds to less than 10 days per month and consider preventative therapy in patients with frequent migraines. Check out our resources online, Drugs for Acute Migraine, and our frequently asked questions on medication overuse headache.
We hope you enjoyed and gained practical insights from listening to this episode. Now that you've listened, Pharmacist subscribers at our Platinum level and higher, and Pharmacy Technician subscribers can receive CE credit. Just log into your Pharmacist letter or Pharmacy Technician's letter account and look for the title of this podcast in the list of available CE courses. We've linked the resources we've mentioned and more on today's topic right in the show notes. Those links will take you straight to our websites, where you'll find even more concise, evidence-based charts, articles, and tools. If you're not yet a subscriber, now's the time. Sign up today to stay ahead with trusted, unbiased insights and continuing education. And as a listener, you can save 10% off a new subscription with code CC1025 at checkout. Also, be sure to explore our other TRC content, podcasts like Medication Talk and Rumor vs. Truth, plus our full Pharmacy Essential Updates webinar series for deeper dives. Thanks for listening, stay sharp, stay current, and we'll catch you next time on Clinical Capsules.